can the ascorbazone protocol be used in pediatrics? And if so, what is the basis of the IVC dosage for pediatric care? And there is a rule called Clark's rule where you take the child's weight, divide it by 150, which gives you a fraction, and you times that the adult dose that you would otherwise be giving the child, and that becomes the pediatric dose for the IV vitamin C. And then it says you list, this is Raynaud's, as a magnesium deficient condition. Is this something that could be treated or reversed with magnesium? Yes, but I think we've got to get out of the habit of thinking of the nutrients as if they were like pharmaceutical agents that here, this is, magnesium is a treatment for Raynaud's, because I would say Raynaud's that person may have a leaky gut, that person may be toxic, that person may have other deficiencies, fatty acid deficiencies, or other things that needs to be addressed. But certainly I would look at magnesium as a major factor. So anytime you want to take one, we can kind of go back and forth.
I was just going to sort of push you out of the way, but...
Well, we can do it right here.
Okay. Since implants are relatively new and involve foreign material in the body, is it possible that we do not know the long-term health consequences of dental implants? I guess it's possible. I mean, we learn new facts every day, but still, historically, implants become something extremely harmful when they become infected. Okay, we do have a difference in materials these days, and we're tending more towards zirconium rather than titanium. But basically, implants appear, so I want to acknowledge the fact that things could change. Implants appear to be a very good alternative when the tooth was extracted properly, and if there was infection in place, as with a root canal treated tooth, the socket was completely cleaned out all the way to the point where you finally got good uninfected bone, and then you allowed full healing of bone in for roughly 6 months, and then you proceed with the implant. And then, very importantly, you pay close attention to gum care, okay? The main way in which you're going to lose those implants down the road is if you don't pay fastidious attention to the gum line around the implant, because that's the main portal that's going to allow new pathogens to come down the side and start an infection at the apex of the prosthesis. So you use a water pick, a little bit of hydrogen peroxide and mouthwash, and you just gently hit that area. You should do it for all your teeth, but definitely you have an implant, do it for the implant. And most people will do well indefinitely. One point, though, is the older the patient, the less long-term success you're going to have. Why? Because there's so many other medical problems going on in the body. There's osteoporosis elsewhere in the body. There's impaired healing elsewhere in the body. So, and generally, they don't take as good a care of it as they get older. So it doesn't mean an older individual, 70 years or more, can't get implants, but you have to follow up carefully so that you haven't let them get infected and let the person get into a severe medical situation before realizing what's going on.
Do you use sodium bicarb in the vitamin C infusion as a buffer to prevent irritation to the vein, and how much? Generally, we have sodium bicarb on hand. There have been times when the compounding pharmacy has not adequately buffered it. Normally, ascorbic acid is buffered with sodium bicarb or with, more likely, sodium hydroxide. And it's already set at the right pH. But occasionally, if it is burning and you've slowed it down and you've adjusted the position of the needle and it still is uncomfortable, occasionally I will have the nurses add 5 or 10 cc's of bicarb, and that will take care of it. So we do use a little bit of bicarb in our IVC push, which I don't know how many of you have had that and we didn't have a chance to go into it. It's a 7.5 gram push that's given over about 5 to 10 minutes, and we put a little bit of, I think 1 cc of bicarb in, since we are giving the the vitamin C pretty fast. But otherwise, that's the only instance that we typically use it. Otherwise, it's there in case there is a pH problem. And some doctors do recommend checking your vitamin C bags to make sure that the pH is properly regulated.
Okay, we have sort of a three-part question here. Number one, what is the best way to prevent CAP, chronic apical periodontitis? I would say die at a young age. die at a young age, and you're going to prevent CAP. Many people develop it over time. Your teeth get brittle. You crack a tooth. You don't necessarily have a cavity. You do get cavities. The bone becomes osteoporotic. Basically, the way you prevent CAP is by staying as healthy as you can so that your teeth are as much a reflection of your health as the rest of your body. But based on the studies around the world, CAP is very common. Chronic degenerative disease in older people is very common, and it's because they're related. So once you're of a significant age, I really don't think if you want to optimally protect your health is that there's any way around doing regular checkups with the 3D imaging that I talked about. In patients who can't get a 3D digital X-ray is the high-sensitivity CRP an accurate screen? I think so. Okay, this is stuff that we're just talking about now and thinking about now. I don't have any big studies. It's actually a study I want to do with Dr. Ron on some of these patients where they come in with XCRP. We have certain interventions. We'll see if the CRP comes down, and then maybe some of those patients will go to the dentist, and if they have some CAP or a root canal tooth or whatever, we see post-procedure if it comes down further. And then conversely, we see long-term, where I do think I can comfortably say it, even though I haven't proved it, the CRP is going to be of tremendous value to you if whatever shape the patient's in, let's say they have a solidly normal CRP, 0.5, for example, and then you check it 3 or 6 months later, and it's 2.5 to 3. And you're not sure what to do, and you check it a few months later, and it's up to 5. You better look like crazy for an infected tooth, okay? Unless they have some other disease that's been flaring, because CRP is a test of generalized inflammatory stress in your body. And certainly an infected tooth is not the only thing that's going to raise your CRP. So if some other disease is raging like crazy, you won't be able to tell until you get that disease under control and then see if you're able to get the CRP back to the previous level that it was. Finally, is there a link between dental disease and atrial fib? I doubt it. The main connection between atrial fib and something is a magnesium deficiency. It's impressive the number of times we've seen new onset premature atrial contractions, atrial fib, PAT, and I can tell you as a cardiologist, we're never taught anything other than just start treating it, okay? They're just out of luck. They're finally getting at that age when stuff's going to go bad. For God's sake, don't think about something as basic as a magnesium deficiency. But magnesium restitution works very well vast majority of the time when these are new onset. Now, when you see them and they've been going on for 3 or 4 years, they do secondary damage to the heart, and that propagates the arrhythmia. But when they say they've just been having palpitations for a few days or a few weeks, they are ripe for being converted permanently if you hop on them really hard with magnesium.
Just a comment about CAP. We do routine nutrient testing, CRP, a number of tests on our staff, myself included, and I've always kept a low CRP. But about a year ago or whenever it was that being on the board, I was invited to do the CT 3D scan up in Calgary. I was very surprised when Dr. Warwick, who is here, sent me a note saying, you have got something that certainly does look like an abscess, and you really ought to think about having that tooth removed. Now, I did have some pain, and but it was not anything outstanding. It felt a little bit like periodontal pain, gum disease pain, and that if I just flossed a little bit better, I would be fine. And so I consulted Dr. Levy and Dr. Kulaks and another dentist who did traditional x-rays and didn't see it. He didn't see it. But nevertheless, I was intent on going ahead and doing it, but like most people, was dragging my feet. 6 months went by, the next board meeting occurred, and the head of the Pure North Synergy Foundation, who knew about this, said, have you had that tooth removed? And I said, no. And so Dr. Warwick, right that moment, took me down to his office, pulled out the tooth, and sent the tooth in, and you saw the report that I showed the first day. It was god-awful. And I think did it smell like it was a bad tooth? Yes. Yeah, that's kind of it was a bad tooth. And so this is to me, it was a very clear illustration of this CAP phenomenon. And I don't think I ever did have an elevated C-reactive protein. So I think you better think in terms of, if you've got any concern at all about your mouth, or if you want to have a baseline, this is where the CT 3D would be a good idea. Dr. Warwick.
Sam Kimball, who we want to speak about this, I'm a dentist, she's a PhD. We've done, I think, about 1,200 CBCTs on patients. And we've looked at root canals, looked at periapical periodontitis, and tried to match it to, we do 3 inflammatory markers quite routinely, CRP, ferritin, and homocysteine. None of those really are related to or correlated to the presence of dental periapical disease. We find a huge scatter. So I don't think it works. I don't think so far. We got to get Sam in for that. Yeah, okay. Yeah. So anyway, that was just make that point.
Hey, while you're here, I've got one more question for you. Okay. Would you routinely, for all chronically ill patients, inject their tonsils with ozone?
Yes.
Okay.
Yeah.
There you go.
Yes.
Thank you.
Yep.
This is a very good question, and it allows me to explain something I want to explain. If all pro-oxidants are toxic, then why is vitamin C not toxic at high doses IV? Okay? Well, number one, I want to clarify, and this is not just a play on words, but vitamin C is not a pro-oxidant, is never a pro-oxidant. Vitamin C does one thing biochemically: it donates electrons, which is an antioxidant activity. But when you get enough vitamin C in an area where the electron that it donates, as in the Fenton reaction, goes from Fe3 plus to Fe2 plus to hydrogen peroxide to hydroxyl radical, and you have a strong oxidant effect, that's what we're talking about when we say vitamin C has a pro-oxidant effect. And if the vitamin C has caused a big upregulation of the Fenton reaction, if it's caused a big detox of pro-oxidant garbage into the blood, if it's lysed a cancer cell and released iron into the blood and pro-oxidant debris, if it's killed a pathogen and done the same thing, yeah, the patient is going to feel bad. It is going to be toxic, and that's what we're talking about, where if we do get a therapeutic effect that we're shooting for with the vitamin C, which usually means detoxing, killing pathogens, killing cancer cells, that's why we follow it up with the low dose, low amount mop-up vitamin C infusion to stop continuing that process and just neutralize the pro-oxidant debris that's come out.
Given the value of sulfate in phase 2 detox, is magnesium sulfate a better choice than magnesium chloride? I mean, I like magnesium sulfate, and I think there are some advantages. We certainly use it when we're going to do IM because magnesium chloride really hurts. But magnesium chloride has some benefit too. Chloride is necessary for making hydrochloric acid, And when you're giving an IV, you're only giving sodium. There's really no chloride in it. And so in general, and also it's kind of like a standard of care thing where we've mostly used magnesium chloride. I think it's less expensive, and it's just been the standard of care. I think at some point we need to address the question, how much good are we getting from the magnesium? I mean, there's always been this, I think it's a story that we put the magnesium in it to prevent spasms of the vein. I don't think that's really the reason. I think somehow it got put in there, and it's been doing a lot of good. And I've been kind of pushing our staff to use more magnesium. There's a question a little bit later on that maybe I can ask Dr. Levy right now. At what rate? What the question is that if you're putting magnesium chloride in the ascorbazone or any one of these IVs that you're given the first half of it pretty fast, let's say 1,000 milligrams a minute, are you in danger of inducing some kind of arrhythmia because you're giving magnesium, or some kind of a cardiac standstill because you're giving magnesium too fast?
Not cardiac standstill. Basically, the only thing you risk, if you will, by giving magnesium too rapidly is a drop in blood pressure. Okay, that's pretty much it. And really, the amounts that are being used and the rates that are being used, that's not really a factor. However, we always have exceptions, so never always be attuned with the nurse, with your patient. And if the patient is getting a little sweaty or this, that, or the other, I mean, check that blood pressure and make sure everything's okay. Because I guarantee you, if the patient is getting sweaty, one of two things is happening. The magnesium went in too quick and the blood pressure is low, or much more likely, they're hypoglycemic.
Yeah. And what is in your crash cart that you could give that patient that would be the antidote to too much magnesium? Calcium, right. Yes. Yeah, go ahead, Dave, come up here.
It occurs to me, in sickle cell patients, the final event that occurs that causes the red cell to collapse is a loss of critical magnesium in the RBC. The magnesium RBC drops too low in the cell. That's what makes the cell sickle. And it occurred to me that because you're using magnesium in your IVC, you may actually be reducing the risk that you'd have a red cell collapse, not just in a sickler, but I mean, maybe even your G6PD patients.
Yeah.
Because magnesium seems to relate in some manner to the integrity of the cell membrane.
Yeah.
Where I was training at Charity Hospital in New Orleans, there was a fair amount of sickle cell anemia, except all the patients called it the sick as hell anemia.
Yeah. Yeah, I think over time, magnesium is probably, it's not just a kind of a convenience thing. I think we need to discern out all the benefits we are getting from putting magnesium in the IV vitamin C that has enhanced the outcome. It's just like a win-win thing to put your magnesium in. The question is how much. And I will say in the thousands of IVCs that we've had at the Riordan Clinic, I can't think of anyone that's had a major hypotensive episode from magnesium.
What is the bioavailability ratio of IV vitamin C to liposomal vitamin C? There's a long answer to this.
Can I just add something?
Okay, sorry, go ahead.
Once again, from my experience in labor and delivery, we use 6 grams of mag sulfate in 30 minutes.
All right.
And that's routine.
Right, okay.
And yeah, the one thing they'll get is a little flushy. They may get a little bit of a blood pressure drop, but we use 6 grams in 30 minutes routinely in the hospital.
What do you put it in?
No, we put it right in. Yeah, we usually put it in 250 cc's of normal saline. We just run it in as fast as we can.
Preeclampsia for?
We usually, for preeclampsia, but also preterm labor. Those are imminent.
Okay.
So.
And what did you say, chloride or sulfate?
Mag sulfate.
Sulfate.
And then then that's our loading dose. And then typically we'll
Right.
go at 2 grams or sometimes
I
1.5.
forgot
I've been
about
asked about mag chloride. Can you use either one? Or?
I never have. We've
Never
always
have.
our standard
Okay.
is using magnesium sulfate.
What do you think is the maximum amount of magnesium sulfate you've given over a 24-hour period, let's say?
I've had patients on for days.
Days.
And we always just watch their deep tendon reflexes and their urine output, of course, for their levels. And some of the nurses get freaked out that I'm old school, so I don't use the actual plasma levels of magnesium, but
Yeah, I don't think they're very helpful.
but a lot of the new doctors are always checking magnesium levels because they get freaked out about it. But I just watch their DTRs and urine output and just their overall sense, and I'll have them on 1.5, 2 grams, 48 hours, 72 hours.
Wow.
But your risk-benefit here is entirely different.
Yeah.
Preeclamptic patient versus
Yeah.
giving a routine IV, the risk-benefit's so much different.
Different, yeah.
Well, once again, we do it also for neuroprotection for the unborn fetus.
Yeah.
For those that are at risk for preterm delivery, and that's been shown to be very, very valuable for preterm infants. So.
Oh, go ahead. You were starting.
So what's the bioavailability of IV vitamin C compared to liposome encapsulated vitamin C? There's a big explanation on that, so I'll try to cut it down to a meaningful soundbite. Oral liposome encapsulated vitamin C is encapsulated by what could best be called an artificial cell, an artificial tiny cell, and it communicates with cells just like cells communicate with each other's with exosomes and microvesicles. Bottom line is when you take liposome encapsulated vitamin C orally, it makes its way all the way into the lymphatics, into the blood, and inside the cell. It doesn't sit there and disperse in the blood, okay? IV obviously goes straight into the blood, and it goes into the blood unencapsulated. So it has no special transport mechanisms to go inside the cell once it's in the blood. And I say I believe because nobody has been able to prove this one way or another except by the clinical observations I made some 10 years ago have sort of gotten immortalized on the internet, which is for certain infections, in some cases acute viral infections, 5 grams of vitamin C, liposome encapsulated, taken orally, had as good or greater an impact than 50 grams given intravenously. And I would submit to you it's only because it gets so effectively inside the cell without the consumption of energy. We saw earlier that when you give IV vitamin C, the reduced vitamin C needs active transport, consume energy to get inside the cell, and the oxidized vitamin C, the DHAA, goes in passively but needs energy consumption to be reduced to active vitamin C inside the cell. So you're robbing Peter to pay Paul. Also, say what type do you prefer? Most of the time, if you made me choose one, I'd take the liposome encapsulated. But there are many circumstances where the IV does a vastly more dramatic job than the lipo, and vice versa. So the real answer to that question is, when I'm sick, I want both.
And to even add to that is when you're using sodium ascorbate and you're doing the bowel tolerance dosing, whatever it is, 10, 12 grams, especially if you're a newbie, you may be doing a tremendous job of cleaning out your gut. You know, we tend to think of the bowel tolerance dose as just a way of determining the dose of vitamin C, but maybe that would be answering the question of how to clean up the gut pretty quickly. Certainly you're going to evacuate the gut, but the vitamin C might itself be changing the flora in a way that's beneficial, as well as helping reverse zonulin and other effects that's causing the leaky gut.
The way the modern diet is constructed, even if it's organic, everything else, everybody produces an enormous amount of anaerobic bacterial toxins in the course of their digestion every day. It would probably take a diet where you just ate one food at a time to really avoid significant rotting and putrefaction of the food. We talked about food combinations the other day. They're very important. But as a practical point, if you don't mind spending a little time on the pot doing a C-flush once a week when you're not at your office, relaxed on a Saturday or Sunday, it's a great positive health habit.
There's for Dr. Taxman.
Okay, so we've got a question. Probiotics, is it helpful to begin during antibiotics or to wait until after to avoid creating antibiotic resistance in the flora? First of all, you're not going to create antibiotic resistance in the flora. You're going to just kill the flora when you do them when you're currently getting an antibiotic. So that's not an issue. But the probiotic that I do recommend when you are on an antibiotic is one that has Saccharomyces boulardii, because it's a commensal yeast and it is not susceptible to the antibiotic.
Good, thank you. If there's any other ones, just chime in. Yeah. Okay, here's a question that comes. It's a perennial question. Are you ready, Tom? So, do we give? Every year it comes up. Do we give glutathione push before the IVC or after the IVC? And here's the thinking. Yes. The thinking, if you give it after the vitamin C, what you've done is whatever vitamin C is in your system, you can recharge it. You can the dehydroascorbate can interact with the glutathione, and the glutathione will recharge it back into the reduced state. The argument for giving it beforehand is, it's not as clear to me, but it's that somehow you would prepare the body so that the body wouldn't use up the vitamin C as fast.
I was told / taught for every 30 milligrams above 60 milligrams of zinc.
Wait a minute. I'm asking you the question.
Oh,
What would you do, before or after?
I
Don't know. It's not clear, is it?
Whichever one got
Anyone in the room have a point?
whichever one got in my hands the first,
Anyone have any experience using?
because they both bolster each
They
other.
both have. Yeah, it's kind of. I guess it's a chicken and egg.
Yeah.
Kind of thing. Yes.
What you're saying is that the glutathione must be separate from the other, but it really doesn't.
Well,
You
I
don't
don't
actually
know.
know whether it should be
This is a
before or
question for
after.
Dr.
That's what I'd like to know.
Dr. Yanagasawa, someone asked me a question about in the HPV protocol, you were putting glutathione in with the vitamin C.
It is amazing that IV vitamin C first, and this quite effective. Then after, I mix with glutathione and vitamin C. And symptoms improving. I tried to the 3 times 12.5 grams IVC. Then after, I put glutathione and IVC. Then definitely progressively improved. That means a mix is okay, I believe, in my experience. Yeah, mix is good.
Okay. No adverse effects or okay. Any precipitation, because I was talking with another patient that sometimes when you mix different things, like for example lipoic acid, if you mix lipoic acid in an IVC bag that has magnesium in it, very often you'll get precipitation, but no precipitation with the glutathione. Not in your case. Yeah, lipoic acid should definitely be separate. Okay. So when do you pre-test for G6PD? I think we've already answered this. We typically, when patients come in, they get their blood drawn immediately, and we automatically do a G6PD, but that we won't get it back till the next day. So we typically will do a low dose, a 15-gram vitamin C, relatively slow, and then if the G6PD is normal, then we'll move on to the next 25-gram dose. So that's how we do that.
What levels of ferritin should we aim for? You want to aim for as low a ferritin as you can get it, as long as you still have a normal blood count. Practically speaking, this works out to about somewhere between 10 and 20. Okay? If you start to get a little anemic, then you can back off, but you still never want a ferritin chronically above 30. Now, is a ferritin above 30 exceedingly harmful? No, it's a linear thing. 30, 40, 50, 100, 200, 300, it gets progressively worse the higher it gets. But as I showed the other day, we have very clear data now to show that the 30 to 400 reference range of LabCorp is 100% outside of the range of normal, because they looked at blood donors. One set of blood donors had an average ferritin of 17. The other group had an average ferritin of 50. And the group that had the average of 17 had much greater elasticity and much less induced vasoconstriction of the blood vessels. Meaning, even though most doctors would consider it to be low, 50 is already exerting toxic effects.
And pleading the fifth. I'm been out of practice for 4 years, and I'm retired.
Do your best.
So no, you'll help me with it. So
Yeah.
I'll make this
Okay, we'll do it together.
a Socratic
You bet.
process. The question was IV vitamin C in gout. Do I have any experience? I've never used IV vitamin C. I was in the U.S. military, and you just couldn't do that kind of stuff. Got into the civilian sector, and I practiced in Illinois, one of the most litigious states, and I didn't do that. And I really didn't understand C until 2011, and that's when I retired. But with respect to gout, help me out for a second. Is it xanthine oxidase, I think? Xanthine oxidase. C impairs xanthine oxidase.
Yeah.
And impairing xanthine oxidase is the medications you use to control gout. And so when you look in the literature, when I look back in my 1956 edition of the Merck Manual, I mean, it showed back then they knew that when you gave oral vitamin C, uric acid went down and you had fewer incidences of gout. The other thing to keep in mind is IVC, oral C is a good pain reliever. I use it in place of anything. I mean, I never have anybody take aspirin, but you use it in place of Tylenol or NSAIDs. You can just have them take 500 or 1,000 milligrams an hour until they don't have pain. I mean, it's a terrific pain medication.
And Dr. Riordan had gout, and he used to tell me that he took his large doses, 10, 12 grams a day. He thought it had a uricosuric effect. I don't know if it does or not, but he did get relief from gout if he took enough vitamin C.
Right, and different organ, but the same basic situation. The rate-limiting step in a conversion of cholesterol to the bile salts is vitamin C dependent. And because we are a critter that just has such pathetic amounts of vitamin C, we tend to have an abnormal ratio of cholesterol to bile acids, and we have a very high propensity compared to the other mammals to get what? Gallstones. So taking C, I'm kind of a in-progress guy, you know.
We all are.
I had a CT scan for back problem, and they found a couple of small gallstones, and the surgeon said, I'd be glad to take those out. And I said, I wouldn't be glad to have them out. So I just ramped up my C. And
So
and said,
veterinarians
"We'll
don't do many cholecystectomies, huh?
see." Veterinarians?
I say they don't do many cholecystectomies.
And I'm not sure what the second one was as a question. It says University of Kansas protocol. I'm not a nurse or a pharmacist, so I can't read the handwriting.
You went to pharmacy school.
I know.
Okay, I can.
Can you-
What they're basically asking here is the University of Kansas protocol, which I will say is the Riordan protocol that someone borrowed, says that only vitamin C for cancer, no additives. And I think the idea here is that there's some concern that perhaps B vitamins may be neutralizing the pro-oxidant effect of IV vitamin C. I don't know if that's been determined or not. So, and it's the same rationale for not doing glutathione after IVC if you're treating a cancer patient, according to an animal study that was done at KU.
Oh, okay. What do I know about the relationship between Helicobacter pylori and ghrelin? Helicobacter pylori is a bacteria that's been around for thousands and thousands and thousands of years. And it's only been, over the last, since Marshall started doing this to himself and diagnosing it and then associating it with gastritis and ulcers. It apparently, Helicobacter will suppress ghrelin. And there's a real, whether or not Helicobacter really represents a pathogen that we have to eliminate all the time, or is it a commensal, which is really kind of a question. I don't aggressively treat patients when I find it incidentally when I'm doing an endoscopy, unless the patient is really having complaints.
There's a book, The Missing Microbes, and I forget who did that, but I think it's Michael someone. But he found that he was bemoaning the fact that H. pylori is essentially gone. It's been eliminated by all the antibiotics. And he said, yes, it does periodically cause, or it did cause some periodic inflammation, but that he felt that maybe that was some kind of a toning effect within the gut in order to stay in shape, kind of a hormesis effect, make it a little bit inflamed in order to toughen it up or something. But he thinks it's really sad that we rarely do find H. pylori anymore. We made it a bad guy, and we stamped it out with triple antibiotics.
Yeah, he actually feels that we eliminated ulcers, but that we've created gastroesophageal reflux in its place.
Yeah, I think you're right. Yep, thank you. Go ahead.
And what feeds that bacterium is iron.
Iron, right.
Okay, is it helpful clinically to measure iron levels in patients who are chronically sick? If by iron levels you mean ferritin levels, yes. There's really not much use for serum iron levels per se. I mean, you basically, however, the one kicker is ferritin is also an acute a reactor to acute inflammation. So in a patient with some sort of acute inflammatory illness, you could get a falsely elevated or higher than it should be level of ferritin. So that's why it's good to get these levels periodically as baseline lab tests on your patients, and then you know if they've really shot up, they certainly didn't accumulate all that iron in a few weeks or a few months, and you have a better idea of what's going on. And secondly, should we continue IVC even after patient feels better post-Lyme disease treatment? Absolutely. Absolutely. Okay? I can't count the number of times I simply refuse to learn the lesson that someone with any infection, acute or chronic, becomes what I consider to be completely normal clinically. And then all of a sudden there's no urgency to take the high doses of vitamin C or whatever, and next thing you know, they've relapsed. So for an acute infection, you want to continue the very high dose vitamin C for at least 2 or 3 days past what you consider to be the patient as completely normal clinically. For a chronic infection like Lyme, you want to continue a fairly vigorous protocol and infusion rate of vitamin C, I would say, for at least 1 week, but 2 weeks or 3 weeks would be even better.
So here's a discussion of, please explain more about ADHD and niacin in children. And is niacin and vitamin C taken together? This gets into the whole question of methylation, and what we're seeing, or what I think I'm seeing, is I'm seeing a lot of kids with very low homocysteine. And Dr. Hyatt, Pratt Hyatt, Dr. Matt, what he was talking about is that if the homocysteine was low, you had to be suspicious that toxicity was a real issue. And I think toxicity is a very real issue in kids, because they don't have a developed detoxification system. They don't have a good blood-brain barrier, which probably means they don't have a good gut barrier, and probably a lot of them have leaky gut, and so they're going to be more susceptible to the toxins than developed adults are. And when that happens, they're going to pull all of their methylation resources towards the production of glutathione. And so when that happens, they're essentially going to become undermethylated. And I think what we're finding when Abram Hoffer was alive, that was like 40 years ago, most of what he was dealing with were paranoid schizophrenics, who are examples of people who are overmethylated. And if you're overmethylated, methylation suppresses gene expression, and this is one of the reasons why Abram used to say, hey, congratulations, you may have schizophrenia, but your chances of getting cancer seem to be much less, because these patients were overmethylated. And niacin works very well at shutting down overmethylation. So I'm not sure I would give a child that's anxious and acting out an overzealous ADHD niacin. Well, that might work for that child, but if the child's tired and can't pay attention and falling asleep in school, niacin may not be the best choice. But I think what you have to do is do the organic acids test and find out where they stand with some of their glutathione, their B6, and maybe look at their zinc levels. I find that the bigger problem is these kids tend to have too much copper and not enough zinc. And so getting their copper zinc level up would be good. Any thoughts you want to add to that, Matt? Okay. Oh, they want you to talk about how infections in the mouth drain down to the breast. I mean, how do we know that?
With regard to yes, okay. How do we know that?
The lymphatics, yeah, drain to just.
Well, we have number one, my nice little anecdotal stories of the ladies with the fever blisters. With the fever blisters getting drainage into their breasts and having severe breast pain after an IV, and then the next day having less pain, and the following day after that having even less pain. And I certainly can't think of any other way to explain that other than the fact that the pro-oxidant debris and the free iron that is released when you lyse herpetic viral particles that are in these lip sores, the lymphatics that drain here, because I had a chart, I went through it too quick, that shows the lymphatics are shared between the mouth and the breast. They just come down like this. Also, again, not a scientific study, but we have definitely seen in our conferences that we go to where they're doing thermography and they have individuals that have root canals or other infected teeth. Not all of them, but on some of them, you can see red lines going straight from the teeth right on down into the breast.
When I was in North Dakota in the Air Force, we had a 19-year-old who had dental extractions, routine dental extractions, and got septic. And he wound up with an empyema, pus on the, outside the lung, inside the chest.
Yeah.
And what had happened was it goes down the carotid artery sheath. You get the infection, and it advances and starts to dissect, and then it just goes straight down. So I mean, the mechanism of getting to the breast wouldn't be a whole lot different. It just, but it was nasty. It's just a terrible thing. He survived.
Okay. Okay, here's a question. In the UK, oncologists don't accept IVC readily and insist there is no research and no evidence. Can you point to evidence in some kind of, what evidence would you use to try to maybe change their mind? I don't know. Can you read that? What evidence? I think my answer to it is, and I think we talked earlier, is that if you probably won't win the day, you're better off going from the perspective that IV vitamin C is an appropriate adjunct in the care of cancer patients, not necessarily in the care of their cancer.
I would paraphrase this question as there's asking, why are oncologists pig-headed? I mean, this applies to medicine, it applies to engineering, it applies to politics, it applies to every walk of human life. People that have done things for a certain amount of time, they're in a position of power, they're making a certain amount of money, they're respected at the university, they're not going to rock the boat. And even though, and this is a hard piece of information to swallow, even though people's lives are on the line, they either don't care or they have enormous rationalizations built inside their mind that I'm not going to look at that piece of information because I know what I'm doing is right and I'm not going to waste my time even trying to evaluate it. That's about as good an answer as I could give.
You draw a plasma of vitamin C, and I've done that. I did that on about 60 patients. They weren't getting better on standard care, and I had them on a lot of C, and you draw the plasma vitamin C, and it's still almost.
Especially if they're on chemo and sick.
And so the idea is the way you push the argument is not to be overtly confrontational initially. Initially, it's an important word there, but to simply draw the plasma C. And because if you're staring at a low C in a patient who's critically ill, sooner or later people get pretty darn uncomfortable. And our goal is to help make them more comfortable with the decision. But I think that stepwise fashion of saying, you know, but I mean, I recently was at a hospital meeting where I was explaining to a number of executives and a pathologist, good pathologist, but said, you know, we shouldn't be treating numbers even when they're 0. and I simply said, I don't think I can respond to that.
Sounds like it came from a pathologist.
Yeah.
He deals with zeros.
Well, that was in response. That was in response to my showing them the New England Journal of Medicine article about the patients who died in ICU in Sydney over the course of the year had undetectable D levels. Undetectable D levels. And then I got the answer of, I don't think we should be treating numbers even when they're 0. And I just said, people are dying. I think we ought to.
Yeah, that's a good point. Okay, Dr. Tech.
All right, well, I do have a question about, could I expand on this concept of worm therapy? And it is, Dr. Sidney Baker is an incredible advocate for worm therapy. What it is, it's Helminth ova that they're incredibly immunogenic. And so you ingest these and it stimulates the immune system. And they've seen some profound effects for not just intestinal inflammation, colitis, inflammatory bowel disease, but he was raving how this would be the next big thing for all inflammatory conditions. So there's only a few, there's a group I think in the UK that makes them commercially, and he's got a group in the United States that does it. You have to, you know, keep doing them. You don't just get like 1 or 2 courses. You just gotta keep them going. But specifically, which worms? You know, there's a, yeah, there's a couple different versions, and if you really wanted to know, I can look it up online too.
Yeah, you have to. I have a patient that has done that with her son, and it was only out of total desperation because it was totally out of her mode of thinking, but they were so dedicated to trying to find something that worked because they were having to call the police to their homes when the child became totally unruly. And so the idea, though, is that because worms are able to set up, maybe you just said this, that they are able to set up a place in the gut, they do have an anti-inflammatory effect so that the immune system in the gut doesn't take them out. So anyway, what we thought we'd do now is that we've got a few minutes left. I've got a lot of cards here. I think what we're going to try to do is create some kind of a knowledge base. This will be a good foundation for to take out of this conference and see if we can put that on our website, or maybe it'd be a good one for the ISOM website, that we would start a list of common questions and like a knowledge base and have these answered. So is there anyone here now that kind of has a question that's, yes, go ahead. Well, I'll tell you this, UBI is a knockout punch in shingles because you've got the varicella virus circulating, and if you do the UBI, you're pulling a little bit of blood out, you're ozonating it and exposing it to UV light and killing the virus, and that becomes an antigen that immediately activates an immune response, and within a day or two, the shingle's gone. Now, I know IV vitamin C can work very well along that line as well. Hey, Victor, I just saw you. We've got a couple questions for you.
Yeah, when I was talking about oncologists, I wasn't talking about you, Victor.
Well, I have a comment about the oncologist. Since I'm an oncologist as well, I never tell them I'm using vitamin C to treat cancer, number one. So that's a good thing. Whenever they ask me, are you curing cancer, treating cancer with vitamin C, I say, I never have. Maybe you have, but I haven't. But what I do is I tell them that it's used for other things, and there's plenty of evidence. For example, if you get Kenneth Block's box paper on metastatic breast cancer, how he treated those patients, including vitamin C and other nutrients, metastatic breast cancer, compare them with a historical control, excellent paper, and better results. Also, we're in the process now. I'm publishing a paper. We have 6 statisticians come to our office and do an audit of the charts in breast cancer, colon cancer, and prostate cancer. And the ones that got chemotherapy, this is exclusively patients that got chemotherapy and intravenous vitamin C, because the main argument with oncologists is that vitamin C will neutralize the chemo and the radiation. And you can quote me on this because we've already spoken on some lectures, and we're close to publishing this data. And we showed that the intravenous vitamin C in patients that got chemotherapy for breast, colon, prostate cancer, all of them had a reduction of their symptomatology, markers, PET-CT findings, CT scan findings, PSAs, CEAs, CA2729, the different markers. We've shown that the markers will go down. In these patients that got the combination, markers did not go up. Maybe they stayed the same, but did not go up, number one. And number two, the patients that, all the patients had major symptoms related to the chemotherapy before the intravenous vitamin C. 95% did not after, or improved after starting the intravenous vitamin C. So that's a good piece of information. And that comes from the San Juan Bautista School of Medicine and the UCC School of Medicine in Puerto Rico. So you can quote that, and I'm one of the authors. Ismael Torres is another one of the authors. I say he's the best medical oncologist in Puerto Rico because he's open-minded.
Send me the reprint when it's available.
Yes. So, okay. So box paper, Marcial Vega's paper. There are other papers that talk about quality of life. There's a recent paper on pancreatic cancer and intravenous vitamin C together as the first treatment, and these patients did much better than historical controls. Now, medical oncologists don't know what to do with that paper. It's been a great paper, statistically speaking, and it was done even though it's a retrospective review, it's not a phase 1 or 2 study, but it doesn't have to be. Pancreatic cancer, stage 3 and 4, is so bad a disease that whenever you have an improvement like this one, it's significant. So they don't know what to do with it. It's similar to the TAC study of chelation therapy, where we have statistical significance in the LAMA study 2 years ago. Cardiologists don't know where to put that. So I feel sorry for them because they don't know what to do with that data. Well, basically, they have to start treating patients. And the other comment I make about using vitamin C during the treatment of cancer, I tell the doctor, we will never interfere with the chemotherapy or radiation. We'll do it 24 hours before or after the chemotherapy. And usually a chemotherapy will have a half-life of 2-3 hours. So you have 5 half-lives. So the chemo is out of the body when you do the vitamin C the next day, or vice versa. The vitamin C will be out of the body if you do it the day before, when the next day the chemo is done. So that's a great argument because that usually disarms them. You are not necessarily saying that vitamin C works. You're just saying it's not going to harm them. And when you throw that argument, they usually say, okay, go ahead, you do it, but it has to be the day before or after, not the same day. And they usually will settle for that. And the other argument is that there is plenty of information for surgeons, for example, that intravenous or oral vitamin C before surgery is definitely the way to go for anyone undergoing any major surgery. There are randomized studies for gastrointestinal surgeries, cosmetic surgeries, chest cavity surgeries, extremity surgeries, orthopedic type of surgeries. So intravenous vitamin C the day before, at the very least the day before, it should be also 2 days before and 3 days before, in my opinion, will definitely do something that almost no surgeon sees, which is almost no hemorrhage during the surgery. And they're usually very impressed following this process, and they start asking questions. What happened? This patient did not bleed during my surgery. They usually bleed like crazy, and it's because of the vitamin C. And also reduces complications, infections, days in the hospital, pain. So it's a very, very, there's plenty of data on that. Now, going back to the chemotherapy and radiation and intravenous vitamin C, I tell them there's plenty of data on treating other problems the patient has, such as arthritis, high blood pressure, fatigue, insomnia, depression, anxiety. There's a lot of information on vitamin C and that. So you say, I also want to help him with that. What you just mentioned about the levels in the urine, very important. The last thing I tell the oncologist is that we're going to monitor the patient. So we do the urine, we do pH in the saliva, and we monitor other things like the blood work and so forth, and they usually go along with that when you're measuring the vitamin C. No, I never used D3 in chikungunya. Since Zika is found in semen 8 months after infection, how long are you treating with IV vitamin C and ozone? Well, I didn't think of that, to use intravenous vitamin C and ozone, but you can do it by mouth. We just don't have the information on that. But I would give vitamin C to everyone in this room, daily, orally, and intravenous maybe every 2 weeks. So consider that, because I do either an IV, chelation, or something intravenous every week. And MRSA, there are randomized studies on MRSA that show that essential oils totally cure MRSA on the skin and on the bone. Essential oils will penetrate up to 4 centimeters. We've been using basil, lavender, tea tree, but tea tree is the one that is, there are randomized studies on tea tree for the treatment of MRSA. Otherwise, the treatment is surgical removal. So you can cure it, heal it with essential oils.
Thank you so much. You know, we started out with the proposition that we would like to look for a unified theory of chronic illness. We talked about redox medicine. We've certainly mentioned the factors that go into redox medicine over and over again. We've also discussed how dysfunction gives rise to all this chronic illness, and that we have to look for all of the root causes and be very thorough in our care of the patients. Did we make some progress? Do you feel like you learned something that was helpful to you that you can bring back to your practice and be refreshed in the idea that what you're doing is making a difference in people's lives? It's just that what we do happens slowly. And this is where having a really good relationship with your patient helps, because it does take time in the healing process. But your conviction and your understanding of what you're doing is what really makes the difference. And so coming to a conference like this and being refreshed in your basic fundamental knowledge, I think, helps you bring that conviction with you. And patients feel it. Patients know it. So, and that's another reason for doing IVC, taking vitamin C yourself, having the experience of how much it can help you. Then you can speak, and they'll know that what you're saying really means something. So thank you, everyone, for coming to Wichita. Thank you for all that you do to help other people. And let's stay in touch. How about it? Thank you.